Hello, everybody, and welcome to our TIF Talk Tuesday. Thank you for joining us this evening. I'm very excited. We have a special guest here today, Dr. Erik Wilson. But before I go into his bio and introduce you formally to him, I do want to remind everyone this is a live event. At any time, if you have any questions, please feel free to type it into the chat section and we will do our best to answer your questions. We also have Lynn McFadden, who is another market development manager here. She is joining us today to help get those questions to Dr. Wilson so he can answer them. So welcome, Dr. Wilson and Lynn, and thank you both for joining us this evening.
Thank you. Thanks, Andrea. Thanks, Lynn.
Thank you.
Appreciate being here.
Thank you. So I do want to introduce everyone to our special guest. He is Dr. Erik Wilson. He is a professor of surgery at McGovern Medical School at the University of Texas Health Science Center at Houston, UTHealth, and the director of the UT Physicians Minimally Invasive Surgeons of Texas. He is the chief of elective general surgery for the Medical School Department of Surgery and is also the medical director of bariatric surgery for the Memorial Hermann Hospital-TMC. Dr. Wilson specializes in bariatric, general, and reflux surgery. He is committed to a personal approach to the surgical care of patients with an emphasis on safe surgery. So again, Dr. Wilson, thank you so much for joining us. We really appreciate you being here with us tonight.
Absolutely. It's an honor to be here. Thanks to y'all and Gastric Solutions for letting me participate.
Of course. So let's go ahead and get started. First thing that patients or people that are always on here wanting to know is, what is GERD? What could patients potentially what kinds of symptoms would they feel if they were suffering from GERD?
So GERD is short term for gastroesophageal reflux disease. And if you listen to the commercials on TV, people call it acid reflux. But it's really more complicated and all encompassing than that, because this is not a disease of just about acid, okay? What happens is things in the stomach that are supposed to stay in the stomach are refluxing or coming up into the esophagus at an abnormal rate. So we have specific anatomy set up in our body. So when we swallow food, it goes down and it doesn't come back up to a great degree. And the digestive processes that occur in our stomach don't also come back up into our esophagus. So the esophagus isn't designed to have things regurgitating up into it on a regular basis from the stomach, but that happens with the disease of GERD. So it's a problem of this valve between the esophagus and the stomach called the lower esophageal sphincter, and it has to do with how that valve intrinsically holds its strength and the shape of it based upon a flap valve mechanism that exists. So it is also the shape of the valve. And then above and below it, there's certain factors that can play into reflux. And this valve goes across the hiatus, which is the diaphragm. Basically, the diaphragm is the muscle that separates our chest and our abdomen. And it has to have a hole in it for the esophagus to go through, because obviously we got to get food from our mouth across our chest and into our abdomen. So there's a diaphragmatic hole. That's called the hiatus. Well, the hiatus, or the diaphragmatic hole, supports that valve and provides extra strength. And sometimes people say they have a hiatal hernia. Well, that's a relaxation of the diaphragm itself. So just the barrier of the reflux valve has three components to it: the shape of it, whether it's a good flat valve, the intrinsic muscle itself of the lower esophagus, and then the diaphragm, which supports that structure and keeps everything in an appropriate position. So that's the valve that can get damaged over time as we get older or gain weight. We can have problems with that valve. And so about 40% of the population have at least some heartburn at least once a month. And 10 to 15% of adult population suffers from daily reflux, where they feel stuff coming up on a regular basis or have heartburn. The acid that's in the stomach, the stomach does produce acid, and it's supposed to produce acid. the disease of reflux is not tied, in a vast majority of cases, it's not tied to too much acid production by the stomach. It's really tied to acid being in the wrong place and coming up because of the valvular problems. So as we get older, as we gain weight, the support structure that holds that valve in the appropriate place starts to degrade. And as that valve starts to slide into the chest a little bit because the support structure is not as good, it gets weaker, and then we start to bring stuff up that we shouldn't bring up. And everyone has a little bit of reflux, but it gets abnormal when it's more than 4% of your day, you're feeling reflux. Now, two other components that play into reflux have to do with not the valve itself, but what's above and below the valve. So if your stomach has problems emptying or doesn't empty as efficiently, you can have more symptoms of reflux because things have to get out of the stomach as well. And then above the valve, the esophagus has to contract and push things down. So when things do reflux up, your esophagus, if it has good motility, can recover that. And that's why people don't have permanent heartburn, because the esophagus will contract and push things back down. So all those things work together to keep us from refluxing. And when one part of those isn't working optimally, or multiple parts aren't working optimally, then we have gastroesophageal reflux disease. And it can be just basic heartburn, or it can progress to you're regurgitating stuff all the time. It's getting into your lungs. You're aspirating on it at night. You're tasting it in the back of your throat on a regular basis. It's getting into your sinuses. It's messing up your teeth. So there's all kinds of extraesophageal problems that can occur from the reflux coming up. And of course, the incidence of esophageal cancer has been going up for the last several decades, and it's really tied to an increase in reflux. And that reflux is probably tied to our diets and our weight. And the acid blocking medications that we've been taking all that time haven't really dropped the incidence of esophageal cancer. So not everyone who has reflux gets esophageal cancer. So I don't want to make people nervous about that. That's a very low incidence, but esophageal cancer growth is tied to gastroesophageal reflux disease. And just treating it with acid blockers in and of itself doesn't really address the entire problem, because this is more than just a disease of acid coming up. It's other things coming up that also can damage the esophagus. Yeah. So that was a long answer, but hopefully that covers.
No, so thorough. Thank you so much. I usually ask other questions preceding that, but you kind of went through everything. One question that we do get a lot from people that are watching is, can or is GERD the same as LPR? We always kind of talk about it, typical symptoms versus atypical, and you touched on that a little bit in regards to the typical heartburn feeling and regurgitation. But to your point, can you talk a little bit more about LPR and like the hoarse voice and that a little bit, if you don't mind?
Sure. Yeah. So if the refluxate goes up the column of the esophagus further, it can get into our upper esophageal area, and then our pharynx, or where our voice box is, and our larynx and our throat, and can create irritation and damage. And so people who have damage to their vocal cords can get hoarseness. I mean, there are patients that come to us because they don't have a lot of heartburn symptoms, because the acid, for whatever reason, their esophagus isn't super sensitive from a sensation sense, but stuff's still coming up and it's irritating their throat. So those are extraesophageal manifestations of reflux. And so some people call that lower pharyngeal reflux. So the refluxate's coming up enough and not clearing back out. And some of it plays into how well the esophagus can clear it back out. If you can't clear it back out and it's coming all the way up, then it's getting into other areas. It's getting in your throat, it's getting in your nasal passages, it's getting in your airway, it's getting in your lungs. And so there are people that get pneumonias because of their reflux. And adult onset asthma, there are people that have had asthma from reactive airway disease from as a child, and sometimes that's tied to reflux, but it's not commonly tied to reflux. But when you get on new onset asthma as an adult, you should really look and see if you have reflux, because that's the #1 cause of new onset asthma in adults is reflux. And it's often tied to your weight. Why is your weight important as it relates to getting reflux? As you add weight, especially belly weight, you put more pressure inside your belly. That puts more pressure on that valve at the diaphragm, and that valve has a tendency to want to start to slip into the chest. And so weight in and of itself can contribute to your reflux. So a lot of patients, as they lose weight, they'll notice that their reflux gets better. And you mentioned earlier that I'm a weight loss surgeon. Sometimes we do weight loss surgery to help people's reflux when they have a whole bunch of excess weight on them.
Yeah, good point. Good point.
Yeah.
That was a perfect segue. I was gonna ask you, I'm glad you brought up the weight part, because I was gonna ask you what are you generally what are your recommendations for managing GERD specific to that, lifestyle, diet changes. And today we were going to talk a little bit more and dive a little bit deeper into kind of the diet and nutrition part of it, right?
Mm-hmm.
So maybe talk a little, if you don't mind, talking a little bit more about what are kind of some things that people can do, before they even do medical therapy and or eventually go to either TIF or the Nissen procedure.
Yeah, so there are patients, obviously patients who have reflux, they know of certain trigger foods. They may be more acidic. You look in the background of my video there, red wine is a great example. I have so many patients say, I can't drink red wine, especially late at night, or I'm going to be having bad reflux. So there are trigger foods like that. More acidic foods can certainly trigger that effect, but they don't in and of themselves, those types of foods don't weaken the motility and intrinsic function of the lower esophageal sphincter. They just increase the amount of acid, and then acid that's coming up from the stomach can trigger it. Oftentimes, people will tie those trigger foods to a heavy meal, and if you're eating a heavy meal, your stomach has more to empty. And if you eat late, the combination of eating a lot, combining it with alcohol in and of itself does affect motility, intrinsic function of the lower esophageal sphincter. So not just wine, but alcohol in general. And so eating late, eating large volumes, alcohol, those types of things set you up for a potentially, tough night of reflux. So specific foods that can play into that are also things called flavonoids, which a lot of people are not super familiar with, but even things like spearmint and peppermint. Caffeine related foods such as like coffee and chocolate. And then of course, fatty foods. Fatty foods tend to slow down the motility of your stomach. And so if your stomach is slowed down, it reduces gastric emptying. And so you eat a heavy fatty meal, oftentimes you can have some reflux from that. So think about alcohol, caffeine, these flavonoids, fatty foods. And if you eat more unhealthily on a regular basis, that's going to result in some weight gain. So I tell people if they really want to work on their reflux, they need to focus on a good, healthy diet. What is that? Well, it's the same type of stuff I talk about when I'm trying to get people to lose weight. Focus on more protein-based, low processed, low carbohydrate types foods, healthy fats as opposed to a lot of animal fats, and eating slowly. We do our fundamental problem, and if I could say one thing to our entire country, is start picking better food and eat it so much slower. We eat way too fast and we eat way too much, because if we eat slower, we eat less. If you eat late, you're working against gravity. If you eat and then you walk around or do some gentle exercise, like going out for a walk after you eat, that can be very helpful because that empties your stomach before you go to bed. So eating small meals also allows the stomach to empty better. Exercise allows better GI motility. Obviously, less weight is less pressure on your diaphragm. So all those things can be very, very helpful as it relates to diet. Now, other lifestyle things is using gravity to your advantage. So sleep with your head a bit elevated if you're having lots of reflux, and get plenty of sleep. That's the other thing. If you're not sleeping well and you're stressed, Those affect all functions of your body, and including your GI tract. Your GI tract has its own neurologic system. It's independent. It has feed-in mechanisms from your brain through sympathetic and parasympathetics that come from your brain, but it works on its own, and it can get discoordinated based upon what we put into our body. So we need to focus on being healthy and eating healthy, and we generally will have less reflux. But if the valve is severely broken, if you've got a significant hiatal hernia where a portion of the stomach's up into the chest, then the valve just can't maintain any competence left. Then you have to look at considering whether you need to get that addressed with some type of procedure.
Yeah. Wow, that was really good information. We never really go that deep into the diet and nutrition, and there's a lot of nuggets that you had just mentioned that I didn't even know about. So thank you for that. I do see quite a few questions popping in, so I'm going to pass it over to Lynn to get some questions asked. Lynn?
Wonderful. Thank you, Andrea, and thank you, Dr. Wilson. We do have 3 questions specifically, so I'll give you one at a time. The first one is from Stacy. She's asking if gastritis is the same as GERD, and if not, how do they differ?
Great question. So gastritis is not exactly GERD. So gastroesophageal reflux disease is stuff coming from the stomach into the esophagus or regurgitating into the esophagus, where gastritis is inflammation of the stomach itself. There is lots of things that can cause gastritis. When we do endoscopy, one of the things we do when we're evaluating patients for reflux is actually just look at their stomach, look at their valve, and look at their esophagus. We often will see some redness in the stomach. Your diet can affect redness or gastritis in your stomach, just like it can affect reflux, but they are separate things. There are specific bacteria that can sometimes cause gastritis. One of them is y'all have commonly heard of, is called Helicobacter pylori or H. pylori. A lot of people are familiar with what that is. And it is a bacteria that breaks down the defense mechanisms of our stomach, and we can get inflammation in our stomach and even ulcers in our stomach. So patients who tend to have ulcers in their stomach often are infected with Helicobacter pylori. It can cause different symptoms. Gastritis can be due to certain medications as well. I should add that, like if you take a lot of non-steroidal anti-inflammatory medications like aspirin, a lot of Motrin or ibuprofen or naproxen or naproxen, Aleve, those things, if you take those regularly, that breaks down the defense mechanisms of the stomach. The stomach's unique in that it can handle acid because it has these protective mucosal barriers for handling the acid, where the esophagus isn't built for that. That's why that valve is so important to protect the esophagus. But if the stomach gets inflamed, it's because some of those protective mechanisms have started to weaken, either from drugs or these bacteria like H. pylori, and you diagnose that and then you treat it accordingly. And usually that can be treated with medicine and doesn't require any type of procedural intervention other than doing a scope and finding it. But there are patients who have gastritis with upper abdominal discomfort and pain, and they think it may be reflux. And sometimes you treat that and the patient doesn't report any more symptoms, and they may not be refluxing that much. So it can be a confusing thing. Is they are separate things, but they can have similar symptoms in certain patients. Usually the gastritis type pain is more of an upper abdominal and maybe just kind of an epigastric milder pain, where heartburn itself is usually a kind of a more intense kind of burning pain in the chest. And then feeling stuff regurgitate up. So there are some differences in the symptoms, but it can be very hard for a patient to tell the difference. So if you're feeling those symptoms, sometimes you just need to come in and get checked out.
That's great. Excellent advice, and thank you for that. We have Rima is asking, if you have a distal spasm in the esophagus, some hyperactivity, she feels it at times, is TIF a possible option for this GERD? Also, mild gastroparesis, I know it depends on the case, but do I have a chance to do a TIF, or is it contraindicated?
So that's a great question. It's certainly not a simple question. So that was a question where obviously she's been thinking about this. Let me talk about briefly what TIF is, just for the audience. TIF is transoral incisionless fundoplication, or fundoplasty, where with down the mouth we reinforce the valve of the stomach around the lower esophageal sphincter and recreate that flat valve and provide support around that. It's done in patients with really small hiatal hernia, so they don't have a lot of prolapse. If the patient does have a hiatal hernia, you can do a TIF in combination with a hiatal hernia repair, which requires small laparoscopic incisions. But TIF is a way to do a less invasive repair of the valve, and is a very good option because it's a partial wrap and it has a pretty low side effect profile. But specifically to her question, patients who have esophageal spasms, there are patients that have extra rigidity or spasticity of certain parts of their esophagus. It can vary from patient to patient, but some people will have some spastic pain related, and it can be related to reflux, but it's not always related to reflux. So when we see a patient that comes in and has esophageal spasm, we need to prove that it's due to reflux. So there's several tests that we do to look at to see if the refluxate itself is causing the spasm or is something else causing the spasm. And there's other things that can cause spasm, things like allergic reactions, foods, and then some things we really don't have great understanding on, but intrinsically some patients just have more spastic problems. And one disease is called achalasia, where the sphincter, instead of being too loose, it's too tight. And sometimes people over time can progress where that lower esophageal sphincter won't relax anymore. It stays too tight for too long. And you diagnose that with something called a manometry, where you look at the segmental pressures of the esophagus with a measuring capsule system. And if that patient said she had that, she might have already had one of those, but that's an important thing to know. And then sometimes we do need to look and see how well the stomach empties. But if the esophageal spasm is due to reflux and the patient has relative preserved emptying of their stomach, if they have some mild delayed gastric emptying, that's not a contraindication to a TIF. But it depends upon mild versus severe. If you have really severe gastric emptying problems, when you do the TIF, they potentially could still have problems with not getting food out of their stomach, and then they could have bloating problems and even recurrences. So it depends upon the severity of the reflux, but we have patients that come in all the time, and the common things we do to evaluate them are look at their stomach with a scope. There's a specific study that can measure the amount of acid that comes up. That's called a pH probe. Then an esophageal motility or manometry is often utilized, and sometimes a gastric emptying study. And patients come sometimes saying, why do you have to do all this to figure out whether you can operate on me? And it's very important to understand the contractility problems that are going on as it relates to the upper abdomen and the gut versus what's mechanically you're dealing with. And that's real important to get across, so you can tell the patient, these are the symptoms I think we're likely to help. These are the symptoms that you still may have some residual problems with. And having that information can be very, very helpful to give the patient an honest approach on the way to address their problem. And I would say patients who go to a doc or surgeon that doesn't do a complete workup, sometimes they'll think that they're going to get their problem handled with one simple thing, and then because it's not been well diagnosed, they can be disappointed. So it's real important to get accurate information, but obviously from that question I can tell that they've already had some of that workup.
Excellent advice too, doctor. Everybody's different, and so it's really a matter of getting your own individual assessment and to proceed from there. The last question, we have two more. I'll just combine them. They're both about diet. Do you recommend a low-carb diet or keto for acid reflux? And then are there any foods that actually help reduce reflux?
So as far as recommending a keto diet, I would argue that you probably need to individualize it to the patient. I certainly wouldn't not recommend a keto diet. So if you do, I guess the best way to answer that question is, it's like doing a vegan diet. For some people that works very, very well, and some people it doesn't work. And the keto diet's the same thing. I am generally in favor of reducing simple and processed carbohydrates, and the keto diet tends to fit into that. So as a general rule, I would be a fan of it, but there are patients who have a ketogenic diet that still have pretty significant reflux. And I guess it depends upon, what aspects of keto they're embracing. If they're embracing a lot of animal fat, sometimes that can slow down their stomach enough where they're still going to have some reflux symptoms. So I'm not opposed to people trying it, but you can't say with a blanket statement that a keto diet is definitely going to help your reflux. If it helps you lose weight, it probably will. So if patients do well and they can stick with it and they maintain and can achieve some decent weight loss, then it probably will help. As far as foods that help prevent reflux, there's not a lot of science on this, but I would say, giving your gut things to work on helps. And so we talk a lot about, staying hydrated, because if you're staying hydrated with lots of water and non-calorie liquids flowing through your gut, that helps lubricate your gut, and your gut tends to work better. The other thing is your gut likes when non-digestible fiber is being taken in on a regular basis. Now, people, when they start fiber sometimes, or fiber supplements, or start trying to increase their fiber in their diet, they sometimes feel initially bloated because your gut has to get used to contracting against it. But a good fiber-based diet can really help with giving your gut, all of your gut, from your mouth all the way down to the bottom, giving your gut something to work on, and that can really help with its function. So I would say 2 general rules are: focus on high fiber foods, focus on low processed foods that aren't, high in sugar, high in starches, that tend to come in packages, focus on more protein intake, and really, try to stay hydrated, drink a decent amount of water on a regular basis. And then again, like I said earlier, eat slowly, slow down, eat less, eat slowly. We eat way too fast and way too much in our country.
Very guilty of that myself. So yeah,
we all
excellent
are.
advice.
We all are. We all have to relearn.
Yeah, especially here in Texas, right, with all the barbecue and taco.
Absolutely. Absolutely.
Lynn, were there any more questions for now?
No, not right now, Andrea. I'll turn it back to you.
Fantastic. Thank you. Now, I know you talked about the TIF procedure, Dr. Wilson, but maybe you can go into the different treatment options for GERD today. What's available today? Obviously, I think you talked about PPIs or medications, and then up to surgery, if you don't mind.
Sure. Yeah. So there's a whole continuum of interventions that we can perform. So the endoluminal procedures, really TIF is the mainstay of that, which is going down the mouth and wrapping or buttressing the stomach around the esophagus to help with that valve. It works best if the patient doesn't have significant hiatal hernia. So they may have more intrinsic weakness of their muscle, but their diaphragm still relatively intact. But like I said earlier, you can do that in conjunction with a hiatal hernia repair. Now, regular surgical approaches often involve going in laparoscopically, usually with 4 or 5 little poke holes about the size of my pinky, using a camera and going in and mobilizing the upper part of the stomach, reducing any hiatal hernia that's there. Oftentimes there is one. And if you have a hiatal hernia, we need to describe it with endoscopy and look at it closely, but then we would repair it at the time of surgery. So we get that stomach out of the chest and back down in the abdomen where the valve and the upper stomach are supposed to be. And then you tighten up the diaphragm around the esophagus. After you do that, then you can do surgically, you can also do a fundoplication. You can wrap the stomach around the esophagus. The most common fundoplication out there still today is called a Nissen fundoplication. It is a full wrap where you can completely wrap the stomach around the esophagus. It does a good job of controlling reflux. It's kind of the old standard for reflux. It does have some side effects. When you do a full wrap, there's a higher incidence of what we call gas bloat and dysphagia. Dysphagia is feeling like stuff hangs up when you eat, and gas bloat is feeling like you're bloated in your abdomen because the air that you've swallowed can't get back up because the valve's so tight. It's what we call a supernormal valve. It's stronger than what God would make. And so in that situation, any air you swallow, and that's the vast majority of the way we get air in our gut, we swallow it. Any air you swallow has got to go out the other end. So people who have full wraps, they're more flatulent. So I tell them, be ready. You may be farting a little more than average. If you want to get in a contest with your family, you're going to be able to win. But until they get out of the habit of swallowing air, people say, well, why would people be swallowing air? Well, if you reflux a lot, one of the ways you can activate your esophagus to push things back down is to swallow. So if you're talking and swallowing, and a lot of people don't even know it, but if they have significant reflux, they get in the habit of swallowing a lot of air without even thinking about it. And then you fix the valve, you make the valve stronger, and they're still swallowing the air because they haven't learned not to. So that's why people can have gas bloat after anti-reflux surgery. And so it takes time to get out of that habit. So it's important to know that before, but they're also not dealing with that regurgitation. They're able to, drink their wine and sleep flat and things like that. Now, there are other ways to repair. Like I said, you could repair the hiatal hernia and do a partial wrap with the TIF, but you can also augment the valve with mechanical augmentation. And there's things like magnets, where it's a magnetic sphincter augmentation, where you put that around the lower esophagus to directly reinforce that. Why is that a good idea? It seems to be a very durable way. There is some dysphagia associated with it. It is an implant, so occasionally it has to come out. But there are patients, especially younger patients, that sometimes consider that as an option because they are hopeful that, we can't prove this yet, but they are hopeful that it might be more durable. We'll have to see. And then the last thing I would say is patients who have significant weight on them and a lot of reflux, sometimes we do weight loss surgery on them. And a Roux-en-Y gastric bypass is a very potent anti-reflux operation in that it allows, even with a weak valve, it allows rapid emptying out of the stomach because the pouch is small and the intestine literally pulls stuff out of that pouch. So there are patients who have significant weight issues that when they come in and they're regurgitating badly, that's the best thing you can do for them. And those are the patients that also may have really severe gastric emptying problems. You can improve gastric emptying with a gastric bypass because you bypass that stomach. Or really severe esophageal motility problems. Sometimes that's the best way to manage their reflux. So even patients who aren't large, sometimes we have to do that procedure because they have such severe motility problems of their stomach or their esophagus.
Wow. Okay. Thank you for that. So can you talk about kind of pre and post-op and recovery? A lot of patients hear about the TIF procedure, but they also hear about the diet that they have to adhere to afterwards. So maybe discuss a little bit what they could expect if they did have the TIF procedure.
Sure, sir. So, preoperatively, we would just want you to eat healthy, and then they tell you not to eat anything the night before you have the procedure. That's basically just let your stomach empty out. So we'll have nothing in there to work around when we're doing the procedure. The TIF procedure, you do it in the hospital. It usually takes about an hour in total. If you have to do a hiatal hernia repair, it can take slightly longer, but it's not a long procedure. There are patients that can go home the same day. A lot of patients will spend one night in the hospital. That's really kind of physician dependent. It depends upon your doc. But when you are tightening up the diaphragm and or also reinforcing the valve, that involves sutures. There's these little sutures that we do with the TIF where we suture the stomach to the esophagus. There's usually around somewhere between 16 and 20. It's pretty common for it to be 14 to 20, somewhere around that range. And that causes some localized swelling, okay? Because the sutures induce some local inflammation, a little bit of just slight bleeding through the wall of the esophagus, enough to cause some swelling. So it's like if you threw a needle on somebody's skin, it's going to swell a little bit. So it swells on the inside too. That swelling makes things feel tight. And if people advance their diet onto solid food immediately, they're going to feel dysphagia. They're going to feel like stuff hangs up in their esophagus. So we progress people fairly slowly onto solid food after anti-reflux surgery, including TIF. And generally we start with them on liquids after they've recovered. So they usually spend one night in the hospital and go home, and they're going to go home on liquids. And I tell patients, it is annoying to be on liquids for 2 weeks, but 2 weeks of liquids gives everything time for that swelling to go down, and you won't be fighting a lot of dysphagia. And so we put people on liquids. And what I mean by liquids, I mean it needs to be pourable without chunks, and generally try to be healthy, some type of protein, liquid protein shakes, soups with protein in them, but not a lot of chunky stuff. So pourable without chunks, 2 weeks, and then you advance slowly. You go to a pureed-ish kind of diet, pretend you don't have teeth for 2 weeks, and then slowly work to soft foods and then solid foods. Usually it's somewhere between 4 and 8 weeks getting to solid food. Once you get to solid food, you will need to focus on chewing well and eating slowly, because that valve, even though it's 6 weeks out, it's still going to mature the scar tissue, and the esophagus and the stomach still have to get recoordinated from the work that we've done. And so, to protect everything, you need to go slowly. And why is it so important? If you create an environment where you're retching or throwing up post-operatively, you can re-tear the diaphragm and get recurrent reflux. And so it's really important if you're going to go through a procedure to help repair your valve, protect it with your diet so you can have good results for a longer period of time. Because the data around anti-reflux surgery is quite remarkable, with the vast majority of people not having to take daily acid blockers, more than 90% not having to take daily acid blockers if we repair their hiatus and also do a TIF or another fundoplasty. So long term, I would say, eat slowly, like I've said earlier, and eat healthy food. Most patients after these procedures, they'll often lose 10 to 15 pounds. Most of the time, they're very happy about it because it's often weight they needed to lose. But there are patients that are quite thin that have bad reflux that we have to do surgery on sometimes. And those patients, I really have to have them focus on making sure they maintain good calorie intake with protein. And they'll still lose a little bit of weight, but they'll still be quite healthy. So that's generally kind of what we focus on after surgery. Sometimes people ask about activity. You don't want a lot of pressure on the diaphragm. There's not big incisions, so there's not like you're going to tear anything in your abdominal wall, but you do want to protect your diaphragm. So I tell people to avoid heavy core workouts for about 4 to 6 weeks, but they can do gentle exercise. They can do, walking and running and light weights and things like that. Just a heavy aggressive core stuff, I have them hold off for 4 to 6 weeks.
Yeah, perfect. And then going back to regular work, just depending on what they do, they can go back.
Yeah, if they do really, really heavy lifting with their work, then it's a longer, but most patients feel good enough to go back to work in less than a week. They're a little bit tired just from the diet being adjusted and getting used to that. The pain is not a super severe thing. Most patients don't complain of much pain after the first 24, 48 hours. Most patients are able to drive within 3 to 4 days because they don't need any pain medicine. Your incisions heal very, very quickly. Oftentimes, patients are like, well, when can I, shower? You can shower almost immediately after surgery. Yeah, it's pretty quick recovery as far as that. The main thing people complain about, even though they're, told up front, is the diet. And the diet does get a little annoying after being on liquids for that long, because it is kind of difficult to be on liquids that long. Not having anything to chew on when you have teeth can be quite frustrating at times. But it's really important just to protect that valve that we've repaired.
Yeah, such great counsel.
Mm-hmm.
And we've talked to a lot of patients who've undergone the TIF procedure, and post-op, they say, when I first heard about it, I thought it was, okay, this is going to be tough. Then they do it, then they lose the weight, and then they're feeling really good. And they're like, I would do it all over again because it was worth it, because now I can drink the wine. I don't have to take my medication every single day or whatnot. So And again, I love your point, protect it. You spent all this time to invest the time and your body to go through the surgery, invest in it and take care of it. So I love that. Well, we've come to the conclusion of our talk today. I do want to give you an opportunity. And I heard at the very beginning, you had one major thing that you would recommend or advise patients, but I'll come back now after everything you said. What's the one thing that you would leave behind to these patients as a recommendation if they are suffering from GERD?
So I would say don't feel like your only option is just to continue to take acid blockers. A significant minority of patients who take PPIs or acid blockers for their reflux are still struggling. And don't feel like you may have your doctor saying, well, that's all we can do. There's lots of other options. And, these are procedures, and I know patients can be nervous about the concept of getting a procedure, but these are very minimally invasive procedures these days. And there's lots of skilled physicians, gastroenterologists, and surgeons that are doing these very, very safely. So find a high volume center that does reflux as a specialty. That is one of their primary specialties, in that they do a lot of foregut surgery. And just go and talk to them and get at minimum, get a good workup done so you know the pros and cons and you know what your esophagus looks like. Then don't hesitate to ask a lot of questions. But I would say don't feel obligated to be stuck there, just continuing to take your acid blockers and not think about anything else because no one else is giving you options. There's plenty of options out there. And you can still have the autonomy and the complete decision making after you're well informed as whether you want to do something or not, because everything's a risk benefit analysis. We didn't talk a lot about this, but there are some risks of just staying on acid blockers all the time. We are eliminating acid out of the stomach. The stomach's supposed to have acid in it. Helps sterilize our gut. It helps us absorb certain things. We can have problems from just taking acid blockers. They're very safe. I don't want to, rag on acid blocking medications, but if you take them decade after decade, it's not uncommon to have some side effects from that as well. So, just be mindful that there are many, many options out there now, and these endoluminal options such as TIF really are expanding the indications for patients. So if you're frustrated at all with your current reflux treatment, or you think you have reflux and you don't know much about it, come see someone who really addresses all aspects of it and learn about it.
I love that. That's great advice. Well, again, and do your research, right? One reason why we do the TIF Talk, so people can hear from the experts themselves and get some more information. So thank you again so much, Dr. Wilson, for taking the time to do this with us tonight. I know us at Gastric Solutions appreciate it, and I know the people that are watching, and thank you to the patients or the people that are watching and asked questions. We appreciate it. There's probably more questions popping up, so we'll get to them. We promise. We have these every Tuesday. I know I said TIF Talk Tuesday because we usually have them on Tuesday. Today is Monday. I do realize if you thought it was Tuesday, it's Monday. So I apologize, but we will be back here next Tuesday. I did want to say, if you're in the Houston area, you can go see Dr. Wilson. If you are not, you can visit GERDhelp.com. On there, we do have a physician locator, and you can type in your state or your zip code and you'll be able to find a physician near you. We also posted a thread. We do have a new patient app for GERD. So if you want to go ahead and download that app, it's free. You can start tracking your symptoms. There's a lot of articles in there and videos. So there's a lot of information on there to learn a little bit more about what you're suffering with if you have GERD, and also what treatment options are available. So again, thank you everybody for joining us this week. We really appreciate it. We will catch you next Tuesday for our next TIF Talk. Thank you very much and have a great evening. And thank you, Dr. Wilson. We appreciate it.
Thank you very much.